You need diagnostics in order to do drug development, to run clinical trials, obviously to screen and diagnose patients, but also for therapy selection, monitoring treatment. Really, they're essential, and we like to talk about them as the GPS of healthcare.
Sure,
really
yeah.
cannot have informed clinical decision making without them.
Welcome to Bostic Health, where we challenge the business of healthcare and explore bold ideas that drive meaningful change.
Well, hello and welcome to another episode of Bostic Health. We're here in the wild at the New Orleans Hyatt for the Executive War College, where multiple diagnostic firms are gathered to talk about the future of healthcare and how diagnostics play a key role. And I have the pleasure of having Susan Van Meter here with me, who's president of ACLA. Thanks for being here.
Oh, it's absolutely my pleasure. Thank you.
And you're a DC-based person. Have you lived in DC for quite a while?
I've lived in DC since the late 90s.
Have you really? I think it's such a cool city.
It's a great city.
I feel like there are so many just smart people there. Every time I go to, which might sound like I'm being sarcastic, and I'm not. It actually is like full of really intelligent people.
I think that's exactly right. We've got great universities, we've got great restaurants and museums, and it's a nice mid-sized city, very navigable. So
Right.
It's a terrific place
And
for
the
folks to visit.
architecture and the
Absolutely.
restaurants and
Absolutely.
so cool.
Yeah.
So you've been at ACLA about 4 years.
That's right.
What brought you there? What were you doing before?
It's a great question. So, and maybe I can just say a word about ACLA.
You can say a word about anything you want.
Okay, perfect. This is exactly the kind of podcast I love. So the ACLA is the American Clinical Laboratory Association. We represent about 40 clinical laboratories, and they run the gamut from different types of labs, from the nation's largest commercial reference laboratories. We have a number of esoteric laboratories, principally, but not exclusively in the cancer space. And we've got some young labs too, that have just entered the market, perhaps with their first proprietary test. And we work to develop policy in coordination with the members that we advocate to advance in order to broaden the reach of diagnostic testing for patients throughout the country.
So you're trying to make it clear that diagnostics and lab are very strategic and have a multitude of positive effects across healthcare.
Yeah, that's exactly right. And policymakers don't often think of labs when they consider the different providers within the healthcare continuum. And so part of our job is to get providers, or policymakers rather, to understand that diagnostics are really essential and foundational to all healthcare delivery. You need diagnostics in order to do drug development, to run clinical trials, obviously to screen and diagnose patients, but also for therapy selection, monitoring treatment. Really, they're essential, and we like to talk about them as the GPS of healthcare.
Sure,
really
yeah.
cannot have informed clinical decision making without them. So that's really a lot of our role, is to educate policymakers about diagnostics.
Well, thank you for doing that. And when you just described that, it reminded me of, so in addition to being the host of the Bostic Health podcast, I am actually the founder and CEO of HC1, which is one of the companies I was sharing with you earlier.
Yeah.
And the reason HC1 exists was that I saw the fact that labs were relegated to this like tactical, very episodic kind of function, and that even the labs themselves were missing the ability to go and play bigger and really explain that there is nothing in healthcare that tells the story of your life and your health better than lab.
Absolutely.
And if you actually look at the lab information in a longitudinal lifetime kind of view, and you apply these exciting new powerful AI technologies to that, the amount of future is so bright you can unlock it's like mind-blowing.
Right. It is staggering to think about the amount of innovation that has had a positive impact on patients just within the last 10 years or so. We recently had the opportunity to talk to some CMS officials about genetic testing in particular.
Right.
And they really took note of the changes that they themselves have seen over the last 10 years and how that's bringing tremendous value to Medicare patients and to the Medicare program overall. So in telling this story, we actually have a new campaign that we are launching this week, and it's principally inside the Beltway. So if you're coming to DC, you might see it, and it's called the No Guessing, Just Knowing campaign.
Okay.
And we really try to bring to life the different facets of diagnostics that are really improving and saving patients' lives. And we're doing that in a number of ways. By focusing on different types of technologies, perhaps it's biomarkers, rapid whole genomic sequencing to really shorten that diagnostic odyssey for kids, right? We have tremendous advances that are able to shorten that time frame to find diagnostics for our diagnosis for our smallest patients with rapid whole genomic sequencing. 40-50% of cases are actionable right away, and that is tremendously helpful, obviously, for patients and providers. And most rare diseases, start in childhood. So we're bringing that story to light and many others. And again, it is about that GPS of healthcare. Every facet of healthcare is dependent upon diagnostics in one way or another.
Yeah, well, whether you're going to have a physical,
yes,
or you are having something that's more serious, you're maybe pregnant or whatever's going on in your life, there's always a blood draw or some type of specimen that's taken.
Right.
And that generates all kinds of data.
Exactly.
And that data unlocks all kinds of value that without it, healthcare can't happen.
Yeah.
And so you're putting a focus on that and putting substance and numbers to that, to the people who decide how this all gets paid for, basically. Is that fair?
That's right. So we're trying to do two things. One is really pull back the lens for policymakers and get them to think about all the things that are important for them and their families in healthcare, right? You said it right. All the data that's in there is driving decision making. Some of the most important decisions of your life are going to be informed by diagnostics. So this no guessing, just knowing campaign is part of it. But it ties into our advocacy related to core issues like reimbursement and addressing the Protecting Access to Medicare Act, or PAMA. That's the policy that governs how Medicare pays labs under the clinical lab fee schedule. It's in tremendous need of foundational reform. So we have legislation, the Results Act, that would secure that long-term foundational reform. So we're using that broad lens of the value of diagnostics in service of not just educating policymakers, but of driving legislative action on the Results Act.
And you're having some success, sounds like.
We are. So the Results Act is bipartisan, as I mentioned. It's been introduced in the House and the Senate last fall in September. We are closing in on 100 co-sponsors, which is terrific. Okay. Really kind of heavily concentrated in the healthcare committees in the House and Senate, which are really strategically important for moving legislation forward. We've had some key milestones that we've hit. I had the great honor of testifying on behalf of clinical laboratories before the House Energy and Commerce Committee on the Results Act just earlier this year. So we are optimistic we're going to be able to move results forward. I think the timeline is more likely to be towards the end of the year, which is typical for Congress, that they'll look post-election to an end-of-year package. But we are making really good progress.
Okay, and then you hope that what you have in there ends up getting all the way through and still is in there.
That's exactly right. Congress is a little bit unpredictable.
I've had some experience with that.
Yes.
And in an example where it didn't come out the way that we had expected, for very petty reasons also, which I can talk to you about that in a separate conversation.
We'll do that offline.
But in any event, there are situations where the payer, the Medicare in this case, is saying, we'll pay you less than what it costs you to do the test. Or, hey, you can do the test, but we're not going to pay you for that. And even if you're demonstrating that it's medically important to do it, it's just there's not really logic there. And I think when I first started my career in healthcare, I had built an e-commerce company that was all about personalizing an experience through e-commerce. And then when I exited that and moved into a job at Ernst & Young, got into healthcare, I was doing consulting, and I could not believe that healthcare wasn't more personalized, because it was logically it should be.
Right.
And then as I peeled back the layers more and more, I realized how many places and ways healthcare just isn't logical. In many ways. It's irrational in many ways.
What's more complicated than thinking about healthcare financing?
Yeah, there's nothing more complicated.
Right.
So are you, when you're going in to represent the interests of the labs that you work with, are you generally going in with a very specific code or test that's at issue, or you're saying this particular test is so critical for these reasons for patient care, and what you've done with this policy related to reimbursement is like crushing the ability to apply that test? Or you brought up genomics, like we've got a company that does medication therapy optimization, and we include pharmacogenetic testing
Yes.
as one of the vectors we analyze in a constellation of others. And that's been one where, frankly, in our model, we don't have to get reimbursed because it's all value-based care. So we're generating our revenue on the savings that we generate. But it's just interesting as my mind starts to rewind through all the experiences I've had and what I've seen. I'd love to know, like, at a very fundamental level, how do you decide what to prioritize?
That is a great question. I mean, we are member driven, right? So we've got a lot of committees and working groups. We've got a fantastic board of directors who are CEOs of leading clinical laboratories. And we work in collaboration on an annual basis with our members to contemplate what are those key priorities that are going to benefit industry if we can advance policy to support what our members are doing in service of patients. So in the reimbursement realm, we have a very detailed conversation. A lot of the focus is going to be on Medicare, PAMA, I mentioned, but also coverage policy, right? Where is national coverage policy lagging? There is a national coverage decision called 90.2 that only allows next-gen sequencing for certain patients with advanced cancer. We would like to open that up so this great technology can be leveraged for individuals with early-stage cancer. It just makes sense given the trajectory of science. We work a lot on coding. Obviously, that's the beginning of the pathway to getting your test paid. Getting the right code and the right code descriptor is enormously important. A lot of other issues within reimbursement, but then we drive decisions about regulation within the members, about what the membership, about what is most important. We were the organization that made the difficult decision, but we did it to challenge the FDA's laboratory developed testing service.
I was going to ask you about that. Yeah. So set that up a bit, because not everybody in our audience is a deep diagnostic lab person. A lot of them are health system or investors, but like this whole LDT situation, start from labs are able to create LDTs and how that was going, and then what happened, and now what you guys are doing about it.
Yeah, no, it's a great question. It's a very complicated area, so I'll try to distill it. Our member companies do work hand in glove with IVD manufacturers and run IVD FDA cleared and approved tests. But many of our members, not most of our members, do develop their own testing services, laboratory developed testing services, which we believe is a professional service and not a medical device. And that has long been our position. And we've had a very good relationship with the FDA over the years, have worked with them as legislation was contemplated a few years ago that would have created a diagnostic specific framework under the FDA. We know from working with our colleagues in the IVD industry that the medical device authorities don't work particularly well for diagnostics for IVDs. So a diagnostic specific framework is really essential. Those discussions on the Hill really petered out. This is the end of 2022. And we went back to the FDA and we encouraged them to continue to work with us on legislation, right? We want a predictable, clear regulatory apparatus for all diagnostics. Unfortunately, the FDA put out a rule that essentially just said all laboratory developed testing services are medical devices and need to come in under the agency. We encouraged them not to finalize that rule, and they did. And the challenge was both on the policy and the legal ground with this. Policy-wise, we would have seen a constriction of test availability. LDTs are often the only tests for certain patient populations, whether they're pediatric or rare disease. They are the cutting edge of cancer diagnostics.
LDTs are filling a lot of niche areas that they allow in the professional service model the lab to innovate.
That's right.
In a more progressive way.
Yes.
And if you say no, it's a medical device, then that requires this massive investment and this time lag and all of this pain that will cause a lot of them just to throw up their hands and say, it doesn't make any sense for me to create this or maintain this pediatric test, for example.
That's right. So we worried a lot about patient access, about test availability, about how innovation happens within diagnostics. But the legal concern was that Congress has never given explicit authority to the FDA to regulate laboratory developed testing services. They are regulated by CMS under CLIA. So we challenged that rule. And last May, the U.S. District Court of Appeals for the D.C. Circuit, the U.S. Court in the Eastern District of Texas. I was thinking about our PAMA lawsuit. That's a whole other legal story. But
You guys have a lot of lawyers.
They are very good.
You probably have a lot of lawyers on your.
Very good for the clinical lab and for patients. Yeah.
Yeah, right.
So we prevailed in a lawsuit. So FDA had to fully vacate the LDT rule.
Okay.
So that's given
that's
us
a huge
greater
victory.
clarity.
That's
It's
a
a
complete
huge
victory. And the bottom line was they were overreaching what the court decided
That's right.
to try to pull in something else.
Yes.
And it's not even worth asking why. It's like you can't control how other people think and feel. Like just let them think and feel how they do. But it never made any sense to me.
It wasn't the right framework.
No.
Right? So
It's
we
not
will
where it fit.
always be willing to have that conversation. You know, I'm eager to see CLIA be updated. It's been some time since it's been updated. We know that CMS is looking to put out an RFI on CLIA within the next couple of months. So we look forward to that.
Okay. That sounds great.
Yeah.
Well, those are some big wins.
Yes.
I think, really quick back on PAMA.
Yes, please.
So lay that out 101. What's it stand for? What's the effect of it? And how much is that a part of the agenda that you have?
Right.
Please,
It is a huge part of our agenda. So PAMA it's a law that governs how the clinical laboratory fee schedule is paid under Medicare. It is the only payment system in Medicare that requires CMS to base Medicare rates on commercial market rates. So in order to do that, CMS needs to understand the commercial market. So on only one occasion has CMS collected data from laboratories. So 2016 commercial market data was collected in 2017 and set rates in 2018. PAMA requires that the volume weighted median of the commercial market rate for any given test, if it is lower than the Medicare rate needs to come down to it in a phased in approach. Here's the massive challenge. CMS collected data from fewer than 1% of labs, and they tended to be the nation's largest labs that have significant scale, among the lowest prices. So you ended up having an artificial sense of where the commercial market was. You drove down Medicare rates more significantly than otherwise would have been the case. And obviously, many contracts, commercial market contracts, are tied to Medicare. So you're not just having an impact on Medicare, you have an impact on the commercial market. And the commercial market data that had to be reported to CMS included Medicare Advantage and Medicaid managed care. Not really what we think about as commercial market plans, right?
Yeah. Not really.
Not
the
really.
opposite.
Exactly. So there were 3 years of reductions totaling about $3.8 billion. This is a small payment system. It's about $8 or $9 billion annually total, to give you some context. And ACLA was able to work with Congress. We have forestalled cuts since 2020. So it's been 6 years of delayed reductions. We're grateful to Congress for having delayed those cuts. They've also delayed data reporting until this May 1st. So we're going to continue to work on the Results Act to address that pending reduction and to improve CMS's access to commercial market data. But what's really important for clinical labs out there right now, and this includes physician office, independent, and hospital outreach labs, is that they understand that under the law right now, beginning May 1 until July 31st, labs have to report commercial market data from the first half of 2025. So that's commercial rate for every test on the lab's menu and associated volume.
And it's aiming at like comprehensive data. So
totally. That's what we need. We need to have all segments report. As we know, in general, hospital labs may have higher reimbursement rates. The more hospital outreach lab data we get in, we think that will help improve things. So we're kind of on a bit of a roadshow. We've been working with our colleagues at the American Hospital Association, the Association of American Medical Colleges, a number of large state hospital associations to make sure that hospital outreach labs are aware. Because we're a little bit concerned that there has been lackluster education thus far. So we're working with CMS and, again, other associations to get out that word so that labs understand the requirement under the law and can avoid a penalty for not reporting.
Okay. Yeah. Well, I knew a lot about PAMA and about this LDT issue, but nowhere near to the level of detail that you shared.
Okay.
And I really commend you for being able to do that in a way that's straightforward, because this is a very complex subject. right?
Yes, it is. Well, thanks for the opportunity. We spend all day, every day thinking about these issues, so it's great to have the chance to talk about them.
Yeah, well, it's awesome to know that you guys are on the job, because for the healthcare system to be healthy, to make patients healthy, the diagnostic companies need to be able to have a fair economic construct.
Right.
If there's no margin, there's no mission.
This is what patients need.
Yeah,
right?
and I think on the upside, like we were talking about before the podcast started, when you truly harness all of these advanced diagnostics and put those in concert with the therapies that are being unlocked,
Yes.
you have this really exciting future of healthcare where hopefully we're able to prevent so many more illnesses, and we're able to help people manage these very serious issues
Absolutely.
without having, such terrible, issues that happen if you're not diagnosed proactively. My mom died of colon cancer at 56.
I'm sorry.
Yeah, that's a big reason that I'm in healthcare.
Yes.
And in her case, it just wasn't nearly as, like, the diagnostic process. She got her physical every year, and just the basic thing of, like, get a colonoscopy.
Yeah.
It's just nobody ever told her to,
Right.
never did. And so by the time she had these symptoms, it was just too late. And that's a very big example of an obvious thing. But when you look at all these ways that, for example, we're predicting now who's going to develop cognitive decline
Yes.
way in advance,
Absolutely.
based on lab values that are from, like,
Yeah.
routine tests that happen over time, by looking at the data more in concert. So anyway, I'm excited about what you're doing. I'd love to continue the
you.
conversation.
That would be great. And I'll just maybe put in a plug, if it's all right with you, for any colleagues of ours that are interested in getting involved. We have a website called stoplabcuts.org.
Stoplabcuts.org. Okay.
Yeah.
All right.
And right on that website, this is squarely focused on PAMA. It takes literally 60 seconds. You can contact your member of Congress and urge them to support the Results Act.
Okay.
We've had over 200,000 messages go into the Hill within the last few months. So it really helps us drive co-sponsors and awareness. And so we'd be grateful if anybody's interested, they take that 60 seconds and go to stoplabcuts.org.
Okay, awesome. So
Thank you.
stoplabcuts.org. You heard it here from Susan, who is the president of ACLA. Well, thank you for being here for another episode of Bostic Health in the Wild. We'll see you next time.